everyone, myself Dr. Nihala Mariyam from the Department of Conservative Dentistry and Endodontics, Yenepoya Dental College. So today I'll be covering the topic Radiographic method of working length determination. So coming to the specific learning objectives, by the end of the session we should be able to know the importance of root apex in endodontic treatment and also to understand the significance of working length in endodontics. Here we'll also know the various radiographic methods of determining working length in detail. Now these are the contents under which I'll be covering. Now coming to the introduction, for the success of endodontic treatment, establishing a correct working length is an important factor. So without establishing a proper working length, we will not be able to clean and obturate the canal completely. So there has been always a controversy related to this topic, that is way to terminate the root canal preparation and obturation. So coming to the terminologies, here we'll see the definition of working length. This definition was given taken from the glossary of endodontics. It states that it is basically the distance from a coronal reference point to the point at which the canal preparation and obturation should be terminating. Coming to the reference point, these are basically the site on the occlusal or the incisal surface from which the measurements should be made. So these reference points are usually for, in case of anterior teeth, we can take incisal edges as a reference point, and when it comes to posteriors, we can keep cusp tip as a reference point. Now coming to the anatomy of the root apex, so let's see in detail how is the anatomical structure. So we know what is pulp and dentine and cementum, which is there in coronal part. It's also present in the apex root on the root. So there is pulp, there is dentine, and root consists of a cementum as well. Along with that, there is when we look into the apex of the root, there is anatomic apex. It is basically the tip or the end of the root, which is determined usually morphologically. And whereas radiographic apex, it is basically the tip or the end of the root, which is determined radiographically. Now let's move on to the other structures which are present on the root apex, that is the apical foramen. These are the main apical opening of the root canal system. So here you can see the F indicates the apical foramen. Now coming to the apical constriction, that is the these are the narrowest portion which is present at the apical portion of the canal. So the narrowest diameter here you can see that is the B, it denotes the apical constriction. Then coming to the cemento-dentinal junction or the CDJ, these are the region where the dentine and the cementum are seen to meet. Now coming to the apical foramen, as I said, it's the main apical opening which is seen on the root canal system. They may not be always present at the center, so it could be it's mostly seen eccentrically located away from the anatomic or the radiographic apex. Why is it so? Because of the continuous deposition of cementum in older patients, this deviation of about 0.5 to 3 millimeter is seen. Now coming to the apical constriction. So here, as I said, here you can see the A indicates the apical minor apical diameter or the apical constriction, whereas the B denotes the major diameter. So this apical constriction is usually 0.5 to 1 millimeter short of the apical foramen, and these minor diameter usually seen to widen apically and it forms a major diameter. So as it widens, it gives an appearance of a funnel shaped. Now way to terminate the root canal system, it's mostly said that we need to terminate the root or instrumentation or the obturation at this part, that is an apical constriction or the minor diameter. Now why is it so? Why do we have to terminate it or the apical constriction? Because these apical constriction, as I said, these are the narrowest diameter of the root canal system, and they are found to have a smallest diameter of the blood supply, which will help us to have a better wound healing. Now coming to the apical constriction classification given by the Dummer, that is Dummer's classification. It is basically classified into type A, B, C and D. So type A is traditional or the single constriction. It is widely seen in most of the patients, and type B is tapering constriction, type C is multi-constricted and type D is a parallel constriction. Now coming to the cementodentinal junction, as I said, it is basically the point at which the dentin and the cementum meets. So here at this point we can see that where the pulpal tissue is going to end, and we can see the beginning of the periodontal tissues. So because of the continuous deposition of the cementum, the location and the diameter of this CDJ can differ considerably. And one more important point to note is that in this CDJ we cannot locate clinically or radiographically. It is solely the histological landmark. Now coming to the difference between, like, what is the distance between the major and the minor apical diameter. So as we can see in the image, the major apical diameter is usually 0.5 to 1 millimeter short of the major apical diameter. So the distance can vary from younger patients to the older patients. So younger patients will have the distance of about 0.5 to millimeters, whereas as the patient gets older, because of the continuous deposition of the cementum, this distance can increase, and it can seen as the of about 0.65 millimeters. Now coming to the significance, what are the importance of working length? Why do we have to know the, why do we have to correctly measure and estimate the working length? What is the importance? So it's basically, it will help us to determine how far our instrument should be placed, and what is the depth of the filling material which has to be given. And this will also help us to reduce any post-operative pain which the patient can feel if the instrumentation is not done accurately. That if we are doing over instrumentation, patient might feel the pain. So all these factors will ultimately result in the determining the success of the treatment. Now coming to the failure to accurately determine the working length, what can happen if the length of the canal, what we have determined, if it is too long than the estimated working length, there could be a perforation of the canal seen. So there could be apical perforation which can be seen if the length is too long, and such cases also may lead to the over obturation of the canal. Then since we have not limited our preparation to the apex, and we have gone beyond the periapical region, there could be increased post-operative pain which could be seen. All these factors will eventually will affect the healing period of the tooth. Now thus they also decrease the success rate of the tooth. So what happens if the working length is short? So here you can see that this picture shows the under obturated tooth. So in this case there was incomplete cleaning of the tooth, there was underfilling of the tooth. All these factors will cause again patient's discomfort. Then also there is incomplete apical seal because it has not reached the apical constriction. Even these factors, even if the length was short or the long, all these factors will lead to the decreased success rate of the tooth. Now coming to how do we prevent the loss of working length. So first and foremost thing is you need to remove all the unsupported enamel, any undermined caries which is present, and any fractured fragment which is present. So you have to remove all of that, and you have to have a proper reference point. Also we have to maintain the apical patency and remove any debris, that is through irrigation, proper irrigation in between each file or in between instrumentation. Then in case if we are doing tooth which has curved canals, so what is the important thing to keep in mind? It might lead to shortening of the working length. So in such cases we have to pre-curve the file which by which we will know that we have maintained the working length. Now how do we measure the working length? So before we start with the working length determination, the first step was the access cavity preparation. So at this step we should make sure that we will have a proper coronal access to the pulp chamber, which will provide a straight line access into the canal orifice, and this will facilitate in having a subsequent canal preparation, and a proper obturation would be possible. So if in case of posterior teeth, there could be a presence of cervical bulge. All this has to be removed, which can hinder the straight line access. And in case of anterior, we might also see the lingual ledge or the bulge which is present. So all this hindrance has to be removed to have a proper straight line access, after which we place the file with the stopper to determine the working length. Now let's move on to the various methods of determining working length. So there is radiographic method as well as non-radiographic method. In case of radiographic methods, it includes Best method, there is Bregman's method, there is Bramtius method, there is Grossman's formula, Ingalls method, which is most widely used method, and Wayne's method, wherein in cases of resorption we use this method, and Cutler's method, which signifies the major and the minor apical diameter, and then radiographic grid, endometric probe, zero radiography, direct digital radiography, which includes again it includes RVG and phosphor imaging system, and then CBCT, it is a three-dimensional radiographic system. Other than the radiographic method, there is a non-radiographic method. There is Sunada method, and there is digital tactile sense, wherein you place the file and you feel the apex. Apical periodontal sensitivity is there, wherein when the patient feels the pain, when the patient feels the pain, we feel that okay, now the file has reached the periodontal system. Then there is the one of the widely used one, it is also used as an adjunct, that is an electronic apex locator, and then there is paper point method, wherein you check for the bleeding spots. Now of all this, we will be dealing with the radiographic method in detail of each method. Okay. So let's move on to the radiographic method. So initially the earlier days for the radiographic method, it was a radiographic apex which was used as a termination point. But as there was an advance, so there was two schools of thought. One school of thought which said that CDJ or the cemento-dentinal junction is impossible to locate clinically. So the radiographic apex was the only reproducible site, and it is used for working length determination. But whereas the other school of thought says that this radiographic apex, it may not be reproducible. Why? Because if there is any if it will depend on the position of the number of factors, such as if there is any tooth angulation, or it depends on the position of the film and the film holder, also adjacent anatomic structures, also if there is overlapping of the two canals, we may not be able to appreciate the radiographic apex. Now coming to the techniques, there are different techniques used to determine the working length using radiography, that is either the paralleling technique or the bisecting angle technique. The paralleling, in case of paralleling technique, here what is done is the receptor is placed parallel to the long axis of the tooth, and the central ray is passed perpendicular to both the long axis of the tooth and the receptor. Whereas in case of bisecting angle technique, the receptor is placed as close to the tooth as possible, and this central ray is passed perpendicular to the line bisecting the tooth as well as the receptor. So it was found that this paralleling technique was more effective because it had since it was parallel and there was no any image distortion. Now coming to if in case there is two superimposed canals, that is in case of maxillary premolars, where you can see there is buccal and the palatal canal. So when you take a radiograph, there could be a superimposition of the roots. So you will not be able to appreciate the apex clearly in such cases, or in cases of mandibular molars, wherein you have the mesiobuccal and the mesolingual canal which is overlapping. So in those cases, how do you take a radiograph? In such cases, there are three different methods which you can follow. Either you have to take two separate radiographs and at a different time, or you can place in case of one canal you can place a K file, and the other canal you can place a H file, and you have to take a radiograph at a different angulation. or else there is one more technique, that is the slob rule, in which the exposed tooth from the mesial or the distal horizontal angle and canal which moves to the same direction, that is same side it is lingual, and which moves to the opposite direction is indicated as the buccal. So here you can see as a X-ray tube head which is changing, the object buccal or closest to the tube head moves opposite to the side of the radiograph when compared to that of the lingual object. Now coming to the various methods, as I said, this best method. Here in best method, what they have done is a steel pin measuring of about 10 millimeter is fixed onto the labial surface of the root with the help of a utility wax, and then keeping this pin parallel to the long axis of the tooth, one radiograph is taken, after which the measurements are done with the help of BW gauge. In case of Bregman's method, here they have used 25 millimeter length of the flat probes and each has a steel blade fixed with an acrylic resin as a stop. So leaving a free end of 10 millimeter for placement into the root canal, and then you take a radiograph, after which the real length of the tooth is measured by real length of the instrument into the apparent length of the tooth by apparent length of the instrument. Now coming to the Bramte's method. In this method they have used the stainless steel probe which has a calibration and various length. So these probes are bent at an right angle, and it is bent in such a way that after which it is inserted partially into the acrylic resin, that its internal surface is in flush with the resin surface containing the tooth surface. So the probe is introduced into the canal in such a way that the resin touches the incisal or the cusp tip, and the radiograph is taken, and the following formula is used to determine the working length. So coming to Grossman's method, it is also known as a mathematical method of working length determination. So it's a very simple method. In this method, what you do is you place the instrument into the canal with the help of a stopper which is fixed at a reference point, and you take a radiograph. After which you measure the working length with the help of the formula, that is actual length of the instrument into the radiographic length of the instrument by radiographic length of the instrument. Now what are the disadvantages? There could be a wrong reading which can occur, which because of the variations in the angles of the radiograph, because of the presence of the curved roots or any double curvatured canals, and also there could be a small error which could be multiplied. Now coming to Ingles method, this is one of the superior method which has been used, and it's widely used method. So in this method what we do is initially we have to remove all the undermined caries or any fractured fragments, and first we need to have a proper reference point. So in case of anteriors, you go for incisal edge as a reference point and a posterior cusp tip. After which you take a preoperative radiograph, and from this radiograph you measure the length of the length of the working length basically. This working length is measured with the help of a ruler, and the same working measurement is carried onto the diagnostic file. So this file is, after that the file is placed into the canal, and and the radiograph is taken, and after which we have to see for the distance between the file where it is ending and the apex. So if the distance of the is more than 1 mm, we have to readjust the file and take one more radiograph. After that, after we get the estimated working length, from this estimated working length we have to reduce 1 millimeters. So this 1 millimeter, why do we have to reduce? It is considered as a safety factor. So we have to reduce 1 millimeter and continue with the instrumentation. Now coming to the veins modification. In this method, this is basically used in cases where we can see any resorption or periapical bone loss. So in case of tooth with, if there is no tooth resorption, we have to keep 1 millimeter as a safety factor. But that is why I have to keep the working length 1 millimeter short of the apex. Then in case of if there is any periapical bone loss, we have to subtract 1.5 millimeters, and if there is periapical bone loss plus there is root apical resorption, then we have to go for 2 millimeter subtraction. Now coming to Cutler's method. So here this is basically based on the major and the minor apical diameter. So what he says that the narrowest diameter of the canal is definitely not the site of exiting of the canal from the tooth, but occur within the dentin. It is just prior to the initial layer of the dentin. This is basically a minor diameter. So it is at this minor diameter canal preparation should be terminating, and we need to build up the apical dentin matrix. He also told that major apical diameter was found to be twice as larger than the minor apical diameter. So how is the technique done? So in Cutler's method, first what we have to do is we need to take a pre-operative radiograph and we need to locate the major and the minor apical diameter. After which we need to estimate the length of the root by measuring with the help of a ruler using on the pre-operative radiograph. Then we estimate the width of the canal. So if you are using the narrow, if the canal is narrow, we have to go for the smaller size file. If the canal is wide, we can go of about 30 to 35 number file. So after that, once this file is selected, we have to set the stopper at the working, set the stopper, and then working length has to be measured. So if the file was found to reaching the major diameter exactly, then we can subtract 0.5 millimeter from the length of the patient in case of younger patients. If see, now the file is reaching the major diameter, that is apical foramen. From there you reduce 0.5 mm for the younger patients, and for older patients you have to reduce 0.6 millimeters. Now the advantage of this technique is there could be a minimal error because we are looking into the minor diameter. But the disadvantage is, since we need to look at the major and the minor apical diameter from the radiograph, it could be it might require higher quality radiograph, and also it could be time consuming, and this procedure was found to be slightly complicated. Now X-ray grid system. Here what they have done is the radiographic grid is superimposed on the radiograph and the calculation is done. So this was found to be easier. There is no need of complicated calculation which is required. Just the grid is there, and you measure from the 5th millimeter, and you take the readings. Then coming to the endometric probe, here in this method the diagnostic file itself has a graduation. So you place the file into the canal and you take a radiograph. On the radiograph you can see the various graduations on the of the file. So but the disadvantage of this one is we require a larger size file to determine the working length. Now coming to the zero radiography. Here what they have done, it was a newer technique. In this technique they have not used film. So image is recorded on a aluminum plate which is coated with the selenium particles. So these plate which is coated with selenium particles, they are subjected to relaxation, by which the older images are removed, after which it is electrostatically charged, and then radiation is projected on these film. Then you get a latent image. From this latent image, it has to be processed, that is using a developer, then you get a positive image. The advantage of this technique was it was found to have a good edge enhancing property, that it gave a good better details. But the disadvantage was, since it has an electric charge and all, in presence of saliva there could be a flow of current which can cause discomfort to the patient. Now moving on to digital radiography, that's one of the widely used technique. That is, in this technique, in this digital image is formed, which is represented by spatially distributed set of discrete sensors and pixels. So this includes radiovisiography and phosphor imaging system. So coming to the RVG or the radiovisiography, it basically has three parts: the radio part, visio part and the graphy part. In case of radio part, this basically consists of a conventional X-ray unit, but it has a precise timer of short exposure times, and here it includes a sensor which is used to record the images. Visio part, as the name suggests, it has a video monitor, and it displays the processing unit. Then graphy part has a display storage apparatus. Now what are the advantages? Since dark room is not required, instant image can be viewed. Then the quality of the image was also found to be better when compared to the normal radiographic method. Then radiation dose was also reduced, and here film is not used, so image distortion because of the bending of the film is also eliminated. Whereas the disadvantage is it requires a larger disk space to store the images, and the sensor, sometimes the sensor could be bulky and it can be difficult to place inside the patient's mouth. Now coming to phosphor imaging system, here image is captured on a phosphor plate as an analog information, and it is converted into a digital format when plate is processed. So what are the advantages? Similar to the RVG, even this method has a lower radiation dose and image is formed instantly, and manipulation is also easier, and receptor size was seen to be same as that of the film. Now disadvantages, it requires a larger disk space to store the images. Now moving on to the CBCT, that is cone beam computed tomography. This basically, now until now what we saw had all these radiographic images gave a two-dimensional view of a 3D object. But here we could see the three-dimensional view of a 3D object. In this method, a conical shape of the beam that scans the patient in a circular path around the vertical axis of the head. Therefore, the drawback of the conventional radiography, that is foreshortening and elongation, are all ruled out. And the scan is usually done with a resolution of 0.3 millimeters. Here, along with just not just the working length determination, we can also know the different anatomical aberrations which can be present. That is, if in case of there is presence of any extra canals, or if there is any calcification of the canal, all this can be noted, and it helps in a better instrumentation of the canal. Also, it will this CBCT has now come, and it will help us to have a minimal invasive endodontics. Now coming to the advantage and the disadvantage of the radiographic method. Advantage was that we could see the anatomy of the teeth, and we could see if there is any curvature or if there is any resorption. All this can be seen through the radiographic method. Then we can also know the relationship between the tooth and the anatomic structures as well. Whereas the disadvantage of it requires now it can the observation can differ from one observer to other, so the interpretation will vary. Then also in case of superimposition of anatomic structures, the radiographic apex may not be clearly visible. Then most of the radiographic method which we saw, it had a two-dimensional view. Then radiation exposure is also a factor. Then we cannot, in case of the if apical foramen has a buccal or the lingual exit, it cannot be interpreted using the radiograph. Now to conclude, the knowledge of the anatomy of the apical third of the root canal is mandatory to carry out successful endodontic procedures. So there is no individual technique which is truly satisfactory in determining the endodontic working length. So here we, along with the radiographic method, that is the most commonly used one being the Ingalls method, we need to use other methods, that is non-radiographic methods such as electronic apex locator, which was shown to have a greater result as an adjunct to determine the working length. These are the reference. Thank you.